we all work as a team, and we want to do the best for the patient. So this is nothing to say that one is better than the other. Both have their place, and nobody's going to be out of business or anything like that. So we are. This was just in the spirit of the academics.
So,
this may seem like a naive question. Could you explain the benefit or the
can you
reason
just
or
speak
the
up a little bit more?
pathophysiology behind root enlargement?
Yeah. So when you place a valve, you got to make sure that you're putting a big enough valve for that patient. If you have, let's say, a patient that's 300 pounds and all their annulus can accommodate is a 21 valve, you're essentially going to be reducing their aortic stenosis from severe down to maybe mild to moderate. And so we want to make sure we get a big enough valve. There's many different ways to do it. Root enlargement, there's a posterior root enlargements that usually increases by one size. You could do a Kono, or you could do a Yang Y incision, and that can increase the size by 2 to 3 sizes. So we want to basically put in an appropriate size valve for that patient.
So I think for the purpose of the debate, they chose the 65 years old patient. So this is obviously a trickier proposition, but let's say that we move that 10 years later. You have a 75, 72 patient that still is in that half group, 65 or 80. And I think that the decision becomes more difficult. If you have a patient that is in the 70s and you can put a valve that is, let's say, a 26 or a 29, a percutaneous valve, I think the argument is much more difficult for surgery in that particular patient, assuming they have normal coronaries and normal LV function. So I think as in the US, at least in an institution like ours, where the mortality is so low for surgery, and the surgery is as good, that when the patient comes to us in the 70s and I say, I want a TAVR, and the annulus is large, it's really tough for the cardiologist to say you should have surgery. Because if that TAVR gave the patient 10 years, he'll be in the 80s. And if he's at 26, then even though you mentioned that the valving valve maybe have a valving TAVR may be higher mortality. But I think probably this patient probably going to go to 90 or 100 with 2 valves. So I don't know. I think the 75 is much more difficult than the 65 or the 85. And if you either have comments about it.
No, I think, again, remember that the average lifespan of United States male is 77 years, still 78 years. So it is not like that at 65 you're going to live 30 years. I hope you do, and I wish for it. But this is in a common person. When people come 65, their kids are out in college. They are now ready to enjoy life at 65. They don't care about what is going to happen at 75. Most of them don't. So I'm just saying that this becomes, what I see. I'm not saying, I on the contrary, tell them, because 65, I really want them to have surgery many times. I say 65 with bicuspid, most of them are bicuspid. I really don't want to do anything. But let's say if they're not bicuspid or tricuspid, and they say that, Samir, I really want you to do the TAVR. Tell me why not. And it is very, very hard. And even if some of them have right just now there's a patient, a cardiologist, who wants to have a TAVR. Now he is a cardiologist. Now what am I going to tell him? And then there's another guy who is a drug rep who says that I want to have TAVR. Now and he has a proximal LAD lesion. I said that, you should have surgery. I called him, we scheduled him for surgery, he canceled it. So what do you do with this thing? This is a reality of life. He says, can you not put a stent? Of course I can put a stent. So this is what is the question.
Yeah. Couple of realities. So let's say, so you have a 0.5% mortality, right? But there's lots of variability. There's surgeons and surgeons and their hospitals.
0.16 in 3 years.
0.16, okay. So surgeons and surgeons and hospitals and hospitals. So your data may not be how many cases you do a day, how many open hearts you do a day.
Me personally?
No. The entire
25 open heart surgeries.
So how many? There are not too many sites that do 25 open heart surgeries a day. No. So the expertise you have developed is amazing, but there is variability. And the other thing is that, let's say, for cost measures or something, somebody's tried to pull this. we're going to do more SAVRs and TAVRs because TAVRs may be more expensive for us and we get reimbursed less. So we're going to offer SAVR instead of TAVR. Then they're going to go to the hospital to the next town and they're going to get the TAVR. So if you don't do it, somebody else will do it because they don't want to be operated. And then the other reality is the variability with surgical outcomes that are not as much with interventional procedures.
Yeah, so at first I just want to address the previous question. So the life expectancy charts of a male in the United States is 77 and female is 81, but that's from birth. That is, if you were born today, that's how long you're expected to live. If you've lived to 65 and you're at 65, your life expectancy is still 26 years. And if you live to 75, your life expectancy is still about 18 years. So, when we think about a 65-year-old, they're not going to die at 77. They're going to still have another 26 years. Are we confident that a strategy of TAVR first is going to get them there? And I would argue that absolutely no. Even for a 75-year-old, if they're the age is just a number. We all know patients who are 75 who look and act like they're 50 and 75 who look and act like they're 95. And so essentially it really just comes down to what you think is the life expectancy as much as you can guess for that patient. If you think that that patient has a long ways to go, they're still better off getting a SAVR as their first option. Now I totally understand that, at the end of the day, for patients, if we're in the United States. This is patients are freely mobile. It's not like in Canada or other countries where patients are limited in their options of where they can go. However, when you talk to patients, of course, some patients have already made up their minds and they're not going to change their minds. However, there's many other patients who will listen to logic and who will listen to reason. And at the end of the day, every conversation that I have with the patient always starts with, what are your goals? What are you trying to achieve? And how we can help you get there. And more times than not, they tell me that their dreams is not just to be alive in 3 months, but their dreams are far down to the future. And we got to come up with a strategy to help them get to that point.
Okay, we've got one last question, and then we'll just survey and see what people are thinking before cutting you loose for a break to come back for the next sessions. Go ahead.
Thank you. This is just a very quick question. Just for the subset of patients that actually have atrial fibrillation, there are some studies that suggest that the longitudinal outcomes are better with SAVR plus atrial fibrillation ablation. How does that play into account when you look at these patients, say TAVR versus SAVR? What factors go through your mind in terms of which patients go in which direction?
In terms of with atrial fibrillation?
Yes. So TAVR versus SAVR plus MAZE at the same time.
Yeah, see, all this data, I have a little bit of a challenge that what kind, you're comparing SAVR without a MAZE with SAVR with MAZE. So this is now, this is a different population, so these different questions. So I think if this kind of questions have to be answered, you have to answer it rigorously with a trial. So there are, like coronary artery disease, there is already a trial which is working on the coronary artery disease TAVR and SAVR versus stent and this thing. So if you are going to do combined procedures, you have to have that kind of data. And we don't have that kind of data right now. So again, in the low-risk population, the AFib is not so common. So this is again something to keep in mind that, and again, when I want to enroll a patient in primary trial, which is mitral clip versus surgery, they all want surgery, no problem. And when I want to enroll a patient in TAVR trial, they do not want surgery because, why is the difference? It's because of the randomized data. It's not because people are informed. People know what they're talking about. So it's not that they are just afraid of surgery. In the past, nobody wanted to join a TAVR trial until all this data became available. So there is definitely a shift. That's what I'm trying to say.
Okay, thank you. So you've heard all the arguments. I'm going to ask you all an easy question first before I really put you on the spot. So which image is going to stick with you the most? The vacation house falling into the ocean or Mick Jagger, who seems to be someone who will dance forever, dancing after his TAVR? Hands up for Mick Jagger. Okay, and hands up for the house, falling in the... I think people really like the house. They maybe because we're here in Florida. But now, if this were you, for those of you who are 65 and under, you can put yourself in this position, but I'm going to ask everybody who's older than 65 to imagine when you were 65. So which would you choose for you? SAVR, hands up, knowing everything you now know. Okay, and TAVR. Now, there are a few hands that didn't go up, but I'm assuming you're kind of on the fence and you're not exactly sure. I'm going to ask one last question. How many of you, and this one you don't really have to answer, but how many of you would recommend one thing for your patients and would do something different for yourself? Okay, one person who's willing to put up his hand. So, all kidding aside, I think this was a really, really great debate. I'm going to be curious myself as to whether or not the next set of guidelines, which they're already starting work on, are going to change that in between zone, because a lot of the data you've heard is relatively new.